Hello and welcome to another edition of Health Matters, brought to you by WCCA TV and the Worcester District Medical Society. I'm Dr. Bruce Karlin, and I'm really excited tonight on our show. We are going to be discussing mental health and how to protect and serve with the mentally fraught. My guest tonight, I'm honored to have Peter Martin, who is a lawyer who concentrates on healthcare law, but he's also been remarkably helpful for the Medical Society in producing a column for us. And with him, we have Officer Angel Rivera and Lieutenant Sean Murtha from the Worcester Police Department. And I welcome to you all.
Thank you.
Thank you.
I speak from personal experience as a physician. And what I'm going to tell you is a very brief story about a Section 12. And Peter Martin will be explaining what a Section 12 is. But we had a fraught situation in the clinic. And for the second time in my life, I called in a Section 12, which is to forcibly have or voluntarily have a patient get a mental health examination in a fraught situation. And I called in at 11:30 in the morning, and I figured, I'm all through with this. I've done my job. And about 4 hours later, Officer Brian Donahue called me back up and said, "Do you really want to go through with this Section 12? He said, "If we require this gentleman to get some intervention, it's going to be just terrible. We've been talking to him for 4 hours." And the officer, just a line officer, knew exactly what to do. I think this is a story that we don't hear very much. And I was frankly ecstatic about the whole interaction. I thought, my God, we see all the bad stuff on TV, and here's just a line officer doing his duty and quieted the situation down beautifully. And ultimately, we were able to remove the Section 12. The emotionally disturbed gentleman was able to get back into his comfort zone, and all was well. So I thought I gave a call to Officer Donahue, and he's the one that introduced me to both Angel Rivera and Sean Murtha of our Worcester Police Department. Both of you have served over 14 years in the department.
Correct.
So seasoned veterans, and we'll deal with Officer Rivera with his knowledge of how the crisis intervention team works, and Lieutenant Murtha is going to teach us a few things about how we're dealing with this on a policy level. But first, thank you, Peter, for being here.
My pleasure.
Can you tell us what Section 12 is?
Sure. Thanks, Dr. Karlin. Section 12 refers to Section 12 of Mass General Laws, Chapter 123. And it is a very specific statute designed to deal with a very specific issue. It is a question of whether or not a physician or a social worker or a nurse specialist in the first instance, or if one of those folks is not available, a police officer can make a determination at the moment as to whether or not a failure to hospitalize a person is going to lead to a likelihood of serious harm due to mental illness. So it's important at the offset to understand what this is not. This determination made at the time, and subject to, of course, judicial review later on in the process, is not a determination of legal competency. It's not a determination that the person has lacked decision-making capacity, as would be invoked in the case of the activation of the healthcare proxy. It's not a question of determining whether someone has criminal responsibility for any charges that are being brought against them. It's a response to a particular issue at a particular point in time when someone is in crisis. And obviously when someone is in crisis or someone sees someone else in crisis, what do? They dial 911. And who shows up? Most likely a police officer. And the question that this whole situation raises, or Section 12 raises, is how do police officers who are not social workers, who are not psychiatrists, how do they handle as you say, a very fraught emotional situation with somebody who is about to lose control or possibly going to lose control? It's going to be a very interesting conversation, I think, today to hear about the steps that are being taken now to try to empower and equip these officers with the wherewithal to deal with the crisis situation in a way that doesn't punish the person for the acts which are symptomatic of the illness, but helps the person get treatment for the illness. That's an important distinction, an important kind of diversion that is, I think, going to be very helpful for the community going forward.
Well, Angel, you're the one that knows about this as part of the crisis intervention team. From my point of view, what I see is, 30 plus years of doing this, I've done this twice. And yet, how many times do we see this kind of crisis show up for the Worcester Police Department?
Well, over the last year in 2020, we've seen over 1,000 Section 12s, not particularly our team and the crisis intervention team, but throughout the entire department.
So that's 3 a day?
Approximately. Sometimes it could be more, some days we might not have any, but,
but
if we take the average, it's over 1,000 within the year
So
period.
we see the tip of the iceberg. What you're doing day to day is dealing with this. So how have you changed what you've been doing in the light of the increased focus on mental health? I mean, certainly the very fact of a crisis intervention team is part of that response. But we were talking with a line officer who knew what to do, just sort of from his police DNA.
So I came onto the team around December of 2015, and prior to that, there was an officer that was assigned to the crisis intervention team. And since then, it has evolved in regards to specific trainings of not only our police officers, but police officers out in central Massachusetts as well. It's a 40-hour training that police officers receive, and it identifies who's an individual in crisis, what is mental illness, what is the overview of severe and persistent mental illness, psychopharmacology, what kind of medication usually individuals are on, de-escalation, autism.
You pass over each of these things like, de-escalation. But this is what Officer Donahue just did naturally. He spent 4 hours. I spent maybe a half an hour filling out all the paperwork, and I said, hey, done. And he spent 4 emotionally fraught hours and used every imaginable skill to get this really troubled individual to calm down, to quietly go back, to talk to the landlord who says, yeah, I know him, he's not going to kill me, and get all the people in the neighborhood who had sort of gathered watching him try to coax this guy out of the house. And, but you say de-escalation. Part of it is your DNA, but part of it is you do some additional training, I'm sure.
Correct. So most of it, when you're dealing with someone who's suffering from mental illness, first of all, you have to be patient. You have to be understanding. You have to be able to, have those actively listening skills and be able to persuade them that, they may need some further assistance, or they may have an understanding like, hey, you know what, I understand you, and you don't need, this is most likely your baseline. And at times, for the situation you're talking about, we have been involved with that particular individual, and there's a record. So every time we go talk to someone, the police officer can look up a particular address, a particular individual, and then we may have had an encounter with them. So we've either had brought a clinician before in the past, we've had prior interactions, so they may have read those particular reports. And in the incident that you had, we were there that morning with that individual. So most likely they have done a history in our master car system and found out, hey, the crisis intervention team has been involved with this individual. Why should we drag this out even longer? And not only that, why traumatize the individual even more?
I didn't know that, and you just did it. But you started to go through some of the other things. You had de-escalation, and I cut you off at that point. What other things do you do in the training of the crisis intervention team?
We do a lot of role-playing, and these role-playing scenarios are scenarios that we've encountered ourselves and during our calls for service, and things that we can improve on these type of calls. We've also, during these role-playing, we're very specific on, having that compassion, having that understanding, listening to that individual. Even as far as, like Lieutenant Murtha said prior, before we met, is to have sort of a background, talk to the family members, finding out, hey, what is it that the individual likes the most? What if you have encountered them in this type of situation, what has helped you to de-escalate, the situation? How did you calm the individual down?
How do you find your way into? Lieutenant Murtha, you were talking earlier about the typical call, which I was totally ignorant of. Why don't you describe what you described to me as a typical call of what leads to a Section 12?
So I think in general, just the job of policing, we don't get called on people's best day. They don't celebrate their graduations with us. They don't, that's not what we're there for. Usually something has gone wrong. There's some problem. And so our job is to get there and figure out what's going on and try to resolve it as peacefully and sometimes quickly. Other times we can take our time. But the example we talked about was there's let's say a teenager who's been depressed, and their parents call because the teenager's saying they might want to, hurt himself or something like that. And so the parents feel like it's out of their control and they want some help. So we go there and we'll end up speaking to the parents and end up speaking to the person involved. And at that point, we can fill out Section 12 paperwork if we think it's necessary. A lot of times the ambulance will be dispatched with us, and if we do think that person has to be Section 12, the ambulance is right there. They can go right to the hospital by ambulance.
So, but you do you sometimes call in Community Health Link and get a clinician involved? Because I'm sort of out there in the wilderness with just primary care patients. I don't see this end of things. So, could you walk us through how a Community Health Link might get involved with that?
Yeah, Angel does this every day, so I think I'll send it over to him.
All right.
So one of the things, when the patrol officer goes to the call and they find someone who is having a bad day, in distress, like Lieutenant Murtha said, not on their best day, we want to ensure that individual is going to be safe within their home or out in the community. For us, we would determine, is this person an immediate threat to themselves or others? And that's basically what we can section for. If we think, hey, something might be off, they're not on the medication, the condition of where they're living, they're really not taking care of themselves, inability for self-care, we will call Community Health Link. They're a mobile response team, and they will come home. They will come over to the resident and evaluate the individual on scene, versus then, escalating the situation. Then we have to either make an arrest or, take them to the hospital. We keep on talking to them until the clinician arrives, and the clinician will go and do an evaluation at their home.
I'm just thinking out loud as I'm seeing this. What percentage of the 1,000 cases do you figure that you have to call in Community Health Link for?
So for the last quarter alone, which we had this would be from March through June, we've had at least 15.
So you would have, so if that's a quarter, that's 300 cases, so 1 in 20 you call Community Health Link for?
Your numbers might be right. I'm not good with numbers.
Yeah, but so 15 out of 300-ish.
Yeah. And the understanding of what we need to have is this is time consuming. This is not something we can rush through. This is not, we have to do this in 20 minutes. When someone is in full psychosis, you need to take your time. The clinician does a thorough evaluation and then make the recommendation whether the individual needs further treatment. But we just don't leave it like, okay, we just evaluated and that's it. They do a full evaluation. They're offered services. They're offered outpatient, services. If they voluntarily want to go into a crisis stabilization unit, that's also offered to them. But it's not just doing an evaluation. It's thorough. I would say similar to what they would have in an emergency room.
Do you think, this is a question to both of you, do you think that that your department is typical of departments across the country? I was so thoroughly impressed by the way things were handled that I said, I think we got to be exceptional. Worcester's got to be the best in the country. But do you think this is happening countrywide, or do you think this is something special about the way Worcester has arranged stuff for its police department?
No, we're certainly not the only ones doing this. I know it's different departments all have their own way of doing things, but there are several big departments who have units similar to Angels. That's become an approach that's in favor now, and we do have a significant number of contacts with mentally ill patients. So the more expertise we have, the better we can handle those calls. So I think departments across the country are moving toward this type of model. I think we're ahead of the curve compared to most. But what do you think, Angel?
So Massachusetts we got funding from the Department of Mental Health to be able to train officers, to be able to expand these to different communities. We've had 2 trainings in the past. For Central Mass, we just had one recently last week, graduate some officers from Shrewsbury Police all the way through Sturbridge. In the past, we've gone all the way up to having officers come to Worcester from Ashby to take this type of training. So we're focused more on police training in order to respond to these calls more adequately and be able to expand our crisis intervention programs throughout Central Mass.
What percentage of your calls do you think are truly due to mental health issues?
I've seen the number of 7% listed. I've seen other numbers too. That's the one that pops in my head that I just saw recently. But it's a wide range. I mean, sometimes we'll go to a call and it's just someone who wants to talk to somebody, maybe wants to ride to the hospital. Other times we have somebody, I had a call, someone was in the middle of the road swinging a machete at cars that were, had people in their vehicles. So it's a wide range of, mental health is a wide umbrella.
He was just looking for a ride.
Yeah, so obviously, it's a huge range, but...
Do you think the number is actually higher than that 7%? I mean, certainly from what we've been talking about here, if we expand the definition of, bad day, I mean, we all have bad days. We don't call it mental illness necessarily, but it borders on it sometimes. And, maybe more of those calls, maybe it's a wider spectrum than we really know.
So most of the data that we have received that coded by calls, our calls for service, we've adopted different types of codes in order to see if we can capture that data, which is, you go to a call, you want the crisis intervention team to follow up, it's coded CIT. If you have gone to a call for service and an individual could have been arrested for a minor offense, trespassing, being disorderly, disturbing the peace, those calls will be coded the crisis diversion, crisis intervention diversion, so CID. So in that way we can
So you're
attention catch
you're
of the
trying to
data.
capture the data to see whether this is much, how big the problem is.
Correct.
I think in our pre-taping call, Peter and I were just absolutely astounded at the breadth of the actual incidence of all this stuff. I had no idea, but when you think about it for more than 20 seconds, that's a lot of your calls, is people having a bad day.
And they need clinical help. They don't necessarily need a police officer, but they need some clinical help. And the police officer responding to the call can be their gateway to getting that kind of treatment. One of the things I've learned in hearing about the CIT program is that some police departments actually now have clinicians stationed in the police stations. I think Framingham, Leominster, and Shrewsbury do that. I'd be interested to hear whether from these folks here whether that's some part of the plan for Worcester, and if so, what kind of role or what value would you find in having sort of embedded clinicians in your office?
The two of you looking at it, I don't know, let you take that.
Yeah, I think there are all kinds of different models we're looking at. I know that City Hall is looking at some ideas of dispatching various types of clinicians or social workers with us on certain calls. Other communities have them go instead of the police. Some go with the police. There are a lot of different models nationally being worked out now. It's a big conversation, and Worcester's certainly in it too. I think over the next year or so, there are going to be more conversations and probably some concrete programs along those lines.
Well, when I hear all this stuff happening, I'm saying, I don't want to be, if the range of stuff is mental illness to, criminal acts, I want the guy that can handle the criminal acts having the clinical training rather than me getting that other training that that's just beyond my ken. And I would think that the discussions going forward are how do we get a better infusion of clinical practice into what you do. I'm already impressed with what you do already, and I'm saying, geez, you just have to broadcast what's going on, and maybe this isn't as big a crisis as we think across the country, but it needs a lot of attention on how to infuse clinicians into this, or clinical thinking into what's going on every day, 3 times a day at least, in Worcester alone. Is some of that discussion going on with the top brass, Lieutenant Murtha?
Yes, I'm not involved in all the discussions, so I can't speak for them, but I know that the city manager has outlined a plan of dispatching clinicians and social workers. I'm not sure of the details of how that's going to happen, to the scene of calls. I know that's something that is under discussion, and there are plans being made now. But like I said, I'm not in all of those meetings, so I don't know exactly how it's going to shake out.
You would hope that some of your knowledge of what's happening on the ground gets infused into that discussion. But I am thoroughly impressed with how it's happening now.
I think what's more not more important, but during this process that we go to expand to look at various programs is the training of the police officers. It's not just mental illness. We've talked about during this training individuals who have a traumatic brain injury that might mimic someone with mental illness, and also the community that have family members that are autistic with autism. I mean, for our specific training, there's 4 hours dedicated just on autism. How to respond, how to talk to an individual, what resources will be available to the family, how to reconnect or connect them to other agencies, to be able to assist that particular family or that family member.
So part of our problem, just as speaking as a primary care guy, is that we don't have those other facilities to connect people to all the time. And I think that's a big shortcoming in our overall healthcare system. But you guys seem to deal with the specific problems that are out of my view. I mean, I deal with a lot of these patients, but I don't see them in their crisis moments. By the time I do see them in some crisis moments, obviously, but being able to respond to that emotionally fraught moment is an impressive skill, and I hope all of your officers work half as well as Officer Donahue did. He was spectacular.
We have, I think, right now we think we have about maybe 70 officers trained.
Out of how many officers on the force? That would be
370 or so.
So you got about a fifth of your force covered.
And we're hoping to train, again, like I said, we're hoping to train area police departments in central Massachusetts so that they can start these type of programs in their communities.
Everyone in the department does receive training in all kinds of different mental health issues, on autism. He's talking about the specialized 40-hour training course for a particular CIT course. And one of the things that everybody does, in addition to every single year at in-service a couple times, we get that kind of training on mental health issues, on autism, on individuals with disabilities. We also have this thing called the Milo program, which is something that it sounds like it's out of a video game or movie or something, but you're in this room and there's a huge screen, and broadcast on the screen is a scenario. And so you have to deal with the situation as you would as an officer if you were there. And there are people who are, basically setting up the scenario, and they can adjust it based on how you do. So there's one where there's someone just walking along a playground, and there's a call for, suspicious male on the playground is making the mothers uncomfortable. And you have to go there and try to talk to them a little bit and figure out what's going on. And you figure out there's nothing sinister about the situation. It's just he has autism. He likes watching the birds there. And so that's the kind of thing that we, try to make sure everybody gets some training.
So as you can, our music is going, and it says, our technical guy, Frank Rocco, is telling us that we've got to end this discussion. My thanks to Lieutenant Murtha, Officer Rivera, Peter Martin, and I'm Dr. Bruce Karlin. Thank you for watching another edition of Health Matters, brought to you by WCCA TV and Worcester District Medical Society. Thank you again.
Thank you.
Went quickly.